Bipolar disorder, previously called manic depression, is a treatable mental health condition that is marked by intense changes in moods, behaviors, thoughts, and energy, and can affect our ability to function or complete day-to-day tasks. It can affect nearly every age group and affects people from all walks of life, regardless of race, ethnicity, or gender. It's also important to note that bipolar disorder is an ancient illness whose symptoms were first observed and noted by the ancient Greek physician Hippocrates in approximately 300 BC. Bipolar disorder affects 2 to 3% of every population in the world, and estimates are that about 46 million people worldwide suffer from the condition. Bipolar disorder isn't a condition that just changes mood. It can alter multiple systems in our bodies, systems that regulate not just emotion, but things like sleep, how we think, our metabolism, our gut motility, our energy, blood pressure, our ability to think and reason, our activity levels, our heart rate, our libido, and our interests. While we know that bipolar disorder is a brain disease, we also know that there is no single area of the brain that controls mood and no single gene that causes bipolar disorder. Pictured here are 4 of the central areas of the brain important in the regulation of mood and the body and brain changes associated with each area. A more modern conception of mood disorders, and bipolar disorders in specific, are that they are the result of a complex dysregulation between how different areas of the brain that are important in regulating moods, thoughts, and behaviors ultimately work, communicate, and interact with one another. So how do providers make a diagnosis of bipolar disorder? Unfortunately, despite numerous advances in medicine, such as imaging studies, blood tests, genetic tests, and other laboratory tests, the only way providers can diagnose bipolar disorder is based solely on taking a careful patient history. Currently, this is true for all psychiatric illnesses, not just bipolar disorder. Many times, having loved ones involved in your care who can also provide information and their view on things can also be very helpful in making an accurate diagnosis. Psychiatrists, psychologists, and other mental health providers rely on the Diagnostic and Statistical Manual of Mental Disorders, or DSM as it is often referred to, now in its 5th edition, to make the diagnosis of any psychiatric disorder. The first edition of the DSM was published in 1952, and the DSM has been revised over the years as new research and observations by researchers, clinicians, and information from patients becomes available. While certainly not a perfect manual, it is quite useful and helpful in having clear criteria to make a diagnosis so that clinicians are consistently using common language and common labels for symptoms and diagnoses. DSM divides mood disorders into 2 broad categories: depressive disorders and bipolar disorders. Among depressive disorders, major depression is the most well-known and commonly diagnosed illness. The DSM has many subcategories of bipolar disorders, but the ones that are most relevant here are bipolar I disorder, bipolar II disorder, and the unspecified or other specified bipolar disorder diagnosis. We'll go into what each one of these means in a few minutes. To start, we should define some commonly used terms when diagnosing bipolar disorder. The first is mania, a distinct period where an individual has an abnormally elevated mood accompanied by an excessive amount of energy or activity. Moods can be euphoric, but irritable moods can also be prominent, or patients can rapidly change from feeling euphoric to extremely irritable. Patients often need much less sleep but find they don't really need it. They may sleep only a few hours but awaken and feel rested and full of energy. Speech can be rapid, pressured, loud, and difficult to interrupt. Patients may talk continuously and be unaware of others' need to speak. The increase in goal-directed activity often consists of excessive planning or participating in multiple activities, which may include job, political, sexual, or religious activities. Individuals in a manic episode may be excessively social, contacting friends or renewing old acquaintances without regard to the time of day or night, or without realizing their interactions may be demanding or intrusive. Patients in manic episodes can also be highly distractible, constantly noticing and being distracted by noises, other conversations around them, or seemingly unimportant details in their environment. Inflated self-esteem is common, ranging from uncritical self-confidence to beliefs of having special talents or abilities that no one else has, to beliefs of having special relationships with famous people or events. Patients in manic episodes can also have racing thoughts, abruptly shifting from one topic to another so that their thought process is difficult and sometimes impossible to follow. They sometimes can feel their thoughts are so crowded it is difficult to express them, or can have their thinking become so disorganized as to be incoherent. The combination of an excessively optimistic mood, grandiosity, and poor judgment can lead to reckless involvement in activities such as spending sprees, giving away possessions, foolish investments, or sexual promiscuity, to name a few. At times, these behaviors can lead to catastrophic financial, occupational, or interpersonal consequences that patients must then try to recover from once their mania resolves. Many or all of these symptoms can combine to ultimately lead to great difficulty in an individual being unable to function, often requiring hospitalization to contain the behaviors and prevent further damage to a person's life. The second mood state that is common in patients with bipolar disorder is depression. During periods of depression, patients can experience a variety of symptoms, including feeling sad or depressed most, if not all of the time, though some may have increased irritability or being short-tempered. Not being able to enjoy activities that were previously pleasurable is almost always present, at least to some degree. Family members may notice that the person is more socially withdrawn or isolative. Appetite changes may involve either loss of appetite or increased appetite, sometimes especially craving sweets or carbohydrates. When appetite changes are severe in either direction, individuals may lose or gain weight without intending to do so. Similarly, sleep changes may involve sleeping too much or too little. Unlike in mania, patients in depressive episodes miss the sleep and often feel chronically tired or exhausted. Some patients may find they are sleeping 12 to 14 hours a day and yet still feel tired or that they need to sleep. Poor energy and fatigue are common in patients suffering from depression. Even the smallest task may seem to require substantial effort or seem insurmountable. Patients may have an inability to sit still, having to pace or wring their hands, or experience the opposite, where their body movements, speech, and thinking are all greatly slowed. These things are always noticeable by others. Feelings of worthlessness or guilt may include unrealistic ideas about self-worth or feeling guilty about minor past failings. Many individuals report difficulty thinking and concentrating or making even minor decisions. This may lead to problems at work or school. In older patients, memory difficulties may be the primary complaint. Thoughts of death, thinking of suicide, or making a suicide attempt can be common as well. These may range from passive wishes to not wake up, or ideas that others around them would be better off if the individual were dead, to recurrent thoughts of suicide, to a specific suicide plan. The occurrence of many of these or all of these symptoms can lead to an inability for an individual to function or the need for hospitalization, depending on the severity of symptoms. If we return to our diagnoses in bipolar disorder, let's look at the differences between bipolar I disorder and bipolar II disorder. To make a diagnosis of bipolar I disorder, you must have at least one lifetime episode of mania. Again, manic symptoms are ones in which patients have intense elevated or irritable moods, accompanied by a great deal of energy and decreased need for sleep. Although not required to make the diagnosis of bipolar I disorder, most patients also have periods of depression that can also have a serious impact on their lives and ability to function. For the diagnosis of bipolar II disorder, patients have to have had at least one lifetime episode of hypomania. Hypomanias are milder forms of mania that often do not last as long as manias, do not lead to major difficulties in functioning, and do not lead to hospitalizations. But patients and often loved ones do notice hypomania as a distinct change in a person's mood, where they are typically more energetic, perhaps more irritable or euphoric, but can also have more interpersonal difficulties like arguments or confrontations. Patients who are diagnosed with bipolar II disorder also have to have at least one lifetime episode of major depression. More often, depression is the predominant mood state that patients experience, and although hypomanias are less severe than manias, bipolar II disorder is no less severe overall than bipolar I disorder, as the recurrent depressions can be quite serious and debilitating for most patients. The reality for most patients is that their symptoms are quite individualized, and many may not necessarily find themselves fitting neatly into the symptoms that make up bipolar I disorder or bipolar II disorder. For these patients, the DSM has the unspecified bipolar disorder category. The unspecified category is usually reserved for people who may have had a manic episode that didn't last long enough to meet the full diagnostic criteria for mania, or for a patient who's had repeated hypomanic episodes but never had a major depressive episode and thus doesn't meet criteria for bipolar II disorder. As clinicians and researchers have learned more about mood disorders over time, we've really come to understand that they exist on a continuous spectrum, ranging from bipolar I disorder on one end and major depression on the other, and with many variations in between. Often these unclear diagnostic groups get called bipolar spectrum disorders. There are some helpful tools in making a diagnosis of bipolar disorder, such as the Mood Disorder Questionnaire, which is a patient self-report form consisting of 17 questions, the Bipolar Spectrum Diagnostic Scale, which is a series of sentences that patients read through about moods and check the ones that apply to them, and then add them up and score them, and then mood charting apps, which can help patients and providers understand more about mood changes over time. All of these tools are available on our website, and there are other videos that explain more about using these tools. But it is important to know that these are just tools and not ways to actually make a diagnosis of bipolar disorder. That is something that only a trained mental health professional can do. While seeing diagnostic criteria laid out on a page or a slide may make it seem that making a diagnosis of bipolar disorder is straightforward, very often making a diagnosis is much more difficult. Making a correct diagnosis cannot be done quickly or haphazardly. It requires considerable training, experience, and skill on the part of a mental health professional. Humans are unique, of course, and no diagnostic label can completely capture your unique situation and experiences. Having your mental health provider get to know you is extremely important in refining a diagnosis. One key to keep in mind when considering a diagnosis of bipolar disorder is to look for clustering of symptoms that cycle together. Many patients may have separate times of sleeplessness, or being impulsive, or being irritable, but when these symptoms begin to frequently co-occur all at the same time in a cycle, it may be more indicative of bipolar disorder. Having the correct diagnosis is extremely important for treatment. Getting an inaccurate diagnosis, say major depression instead of bipolar disorder, can lead to treatments that ultimately make you worse, like using antidepressants instead of a mood stabilizer. And finally, and this is really the basis of this entire video series and website, is that knowledge is power. Understanding how the diagnosis of bipolar disorder is made and how these symptoms manifest themselves in you will go a long way in helping you prevent these episodes from spiraling out of control in the future.